ಇದನ್ನ ಚೆಕ್ ಮಾಡ್ಕೊಂಬಿಡಿ ಆಮೇಲೆ.
You know when this will come? This I opened here. It will be here. The video also.
ಆನ್ ಮಾಡಬೇಡಿ, ಇದು ಒಂದು ನಿಮಿಷ ಆನ್ ಮಾಡಿ. After open summary, you're going to present. I will be talking. I'll start saying this was a rich social media experience as well for us. That is the cue for you to change the screen.
Good afternoon to all of you. As we move closer to the end of the conference, we are about to start what seems to be a very interesting session, a dialogue with policymakers. So
it'll take quite some time. It'll take a few minutes.
The general format would be that we have among us some eminent policymakers from the state and from the national governments, and we'll engage them into a discussion, and we'll briefly provide you the summary of what has transpired in last 1.5 days. So I first would require, I will invite our panelists to please come and take a seat on the dais. I kindly request Dr. Soumya Swaminathan. Ma'am, if you can please come and take a seat on the dais. Dr. Sanjeev Kumar. Sir, you are most welcome to please come and take a seat on the dais. Dr. Suresh Mohammed, if he is around in the audience, or else he will be joining us very soon. Dr. Suresh Mohammed and Dr. Sadhna Raju. Ma'am, please come.
Madam,
I'd like to introduce my colleague, Dr. Prashant. Dr. Prashant is from Institute of Public Health, and he will be joining me in facilitating this dialogue.
Thank you. Mic on idea. Thank you, Upen, and a warm welcome to our distinguished panelists. I would like to quickly introduce this panel we have today, as well as share with you what is the purpose of bringing these people together at EPHP. Firstly, we have with us, we are very privileged to have with us Dr. Soumya Swaminathan. She is the Director General of ICMR, as well as the Secretary of the Department of Health Research. Something very special about her, it has been mentioned before in the morning as well by Sunil, is that she's had this very long, illustrious career as a researcher, and today she sits in a position where she could influence research and how it is done in the country. Thank you very much, ma'am, for making it to our panel, and we are very privileged to have you among us. We have with us Dr. Sanjeev Kumar. The presence of Dr. Sanjeev Kumar in today's panel is extremely important, I think, because Dr. Sanjeev leads the National Health Systems Resource Center, and this body is an important technical support body for the Government of India, an important body that contributes to not only policy making as well as program implementation through its excellent guidelines and other documents that it periodically brings out. Thank you very much, sir, for being there all the days as well as participating in our last panel. We are just joined by Dr. Suresh Mohammed. Welcome, sir. And Dr. Suresh Mohammed has had a very interesting presence as well. He's had the good fortune of looking at the National Health Mission from two very important places, at the Government of India and in the Government of Karnataka. I don't know how many people have looked at the same program from two different places, and a lot of research is clearly showing that your perspective on health policy depends on where you sit, and there is no one answer to what has to be done. So we are really happy to have you with us, and that you're participating in this final panel. And we were supposed to have with us Dr. Shalini Rajneesh, who is the Health Secretary of Karnataka. Ma'am has just sent a message. She's been quite unwell for the last 2 days. She was really hoping to make it to the panel, but she wishes us a grand success. And since we are live streaming the event, we have shared the link with her. I sure hope that she's able to watch the proceedings as well. But meanwhile, not to be disappointed at all about the Government of Karnataka's representation, we have with us Dr. Sadhana. Dr. Sadhana is the Executive Director of the State Health Systems Resource Center, the counterpart of the National Health Systems Resource Center at the state government. And it is also an important body that is contributing to policy making as well as program implementation in the state level. Thank you very much, ma'am, that you are here. We are very happy to have all of you with us.
Thank you, Prashant. So I guess before we start and engage our eminent panelists into discussion, we both would like to quickly take you through what transpired in last 1.5 days of EPHP. Well, I'm not trying to attempt to summarize the proceedings. That's going to be too difficult at such a short notice. Can I have the presentation video up? And as you all are aware, we have an abstract book which is published as a special supplement of BMJ Global Health, and it is already up on BMJ Global Health website. It is freely downloadable, and I guess in your delegate kits you already have got the soft copy. So what I'm trying to do is just to quickly take you through what are the kind of themes that were deliberated during the last 2 days. So we started with a panel discussion on better understanding health equity, where I guess we talked about what is the status of health equity research in India, globally in general, and particularly in India, and what kind of methodological issues that we face, intersectionality in health equity research, etc. Then we had concurrent sessions on various themes. One of the theme was inequity in maternal health care. And we had 2 concurrent sessions, total 6 studies being presented on this very important issue. We had a theme on migration, poverty, and health of urban population. Again, we had 6 studies where some of the studies focused on National Urban Health Mission and what are the broad determinants of urban health, while others were more micro studies exploring inequities among migrant population and among urban slums. Then we had a concurrent session on role of treatment and cost. So here were the presentations which try to reflect on how largely out-of-pocket expenditures on treatments affects inequities in health. And the session was followed by another one on insurance and how the prevailing insurance schemes in India, whether they are providing equitable financial protection. So there were studies around RSPY and how it helps people. There were 2 another concurrent sessions. So total 6 studies being presented on the theme of food, nutrition, and health. Interestingly, nearly half of the studies were more about child malnutrition and various determinants and inequities within that, while the others focused on the role of food industry. So the broader determinants of food security and food industry, how they imply on the status of nutrition. We had an interesting session on equitable healthcare provision, where there were studies looking at health services research and trying to bring out on how to move towards a more equitable healthcare delivery. We had 2 interesting sessions which focused on more community-led activities and the local actors and how they play a role in universal healthcare. So the studies focused on role of Panchayati Raj institutions in healthcare. There were studies around how village level committees, different kind of bodies at local level, how they are engaging in healthcare, the district level planning processes. So basically more local view of healthcare system. Then we had a series of organized sessions yesterday. There was this session by WHO Alliance on Policy and Health System Research, which brought interestingly 3 researchers from different sites in India and correspondingly 3 policymakers from those sites and promoted a dialogue among them. There was another interesting session by Poverty Action Lab on reflecting again a kind of a dialogue between researchers and policymakers on how to get research into policy. Another interesting session on participatory research methodologies from Karnataka, from tribal district of Karnataka. And we had one session on how intersectoral action can be promoted in health and a case of tobacco control in Karnataka. So another organized session on health inequity. And then we had today morning a panel discussion. I'm sure all of you enjoyed it a lot. So we had quite good mix of policymakers across Indian states, and deliberated on the nature of policy making, and how can we ensure that we can move towards more informed policy making. We had concurrent sessions on how to get research into to inform better policy and practice. 6 studies ranging from role of media to capacity building, better communications, etc. Another 6 studies as part of 2 concurrent sessions deliberating on how macro policies, both at international level, like access to medicines, but more also at a national level, the World Bank funded projects, and how these initiatives are impacting health inequity scenario in India. We had one session on some of the training initiatives, and yeah, with that, I think this is just a brief snapshot of what transpired in last 1.5 days. We had more than 300 delegates participating throughout. And yeah, I hope you all enjoyed. Maybe I understand that there is more to than what we just participated physically here. And
Yeah.
maybe Prashant, you can help us to give a glimpse of social media world.
Yeah. So we tried our best at sort of taking this discussion forward on social media as well. There's been a very interesting campaign over the last few weeks led by Diljit and colleagues who are sitting at that desk. So they've been constantly tweeting out generally interesting, provocative pieces that came up during discussions, and trying to engage also. Now, over the last few years, most government departments are on Twitter. Some are very active, some are less. And we have tried to tag all respective departments in some of this discussion. Niti Aayog, for example, has been very constantly tagged in many of the sound bites that we captured. So that's also something that's been going on. We have just tried to put together a collage of the different people who engaged with us, or we engaged with, on Twitter on our left. I'm really sorry that the panelists will not be able to get a good glimpse of it. But there's a variety of actors out there. Some of these are policy advocates. We have some police officers who engaged. WHO and UNICEF were constantly tagged. Some of these people are, of course, our colleagues. Some people from here, young researchers like Rajiv, for example, Gupteshwar, and many of you have been quite active, and you've been using the hashtag EPHP 2016 rather well. I thought I'll quickly, some of the themes that came on Twitter, they are quite interesting. One reflection, one theme that comes almost like, I'm now going to do like a quick qualitative inquiry on the kind of notes I have here. One theme that came was on what is the sort of the role of short-term research projects really, if we are talking of equity and health equity. There was some exchange around that, some people saying yes and some people saying no. There was this was a very nice one. I think Sunil Nandaraj has the tendency to come up with these kind of assertions, which is really gets us thinking. Have we killed primary health services by providing condoms and oral pills than a whole range of curative services? He says, intrigued at EPHP 2016. There was also some tweets around the changing role of civil societies. Who are civil societies representing? Are they representing the real interests, or are they representing their own interests? And there were some interesting provocative exchanges around that. From the participatory action research session, we had a bunch of tribal field investigators from a participatory action research program from Chamarajanagar district. From their audience there were tweeting about more focus on tribal health, more tribal researchers themselves rather than others going and immersing themselves in this area. Lot of themes centered around community participation from the session that Dr. Balasubramaniam led on whether we are reducing community participation to state-led engagement or a state-led sort of instrumentalization of community participation. Many people weighed in on that, some in favor, some saying, well, this is a process, you can't achieve community participation in a day. Many others agreeing and saying something is seriously wrong with community participation and the way we do it. Lot of discussion around doctors and how doctor-centered our public health discourse has become, and how there is just no representation from nurses, from midwives, from pharmacists and various other cadres of health workers who are missing both in the research agenda as well as in the human resources for health agenda. Some tweets around that. There was this one, I think from today morning session with Dr. Sundari Ravindran about, I think she was quoting another researcher. Can you make omelets without breaking eggs? Something that Werner Source, my colleague, tweeted about. And I think it was alluding to the need to really disrupt and question the boundaries of research itself, because we are talking of researching social disadvantage, the need to push our methods also to capture all of that. Many other tweets, people pointing out the Nagaland model of community participation being something to think about. Another nice one, if a policy does not consider equity explicitly, it will clearly increase inequity. Again from Werner. So this is some of the conversations. There's a lot of tweets to talk about. I think I'll occupy too much. But what I would say is, those of you who are still on Twitter and want to continue the conversation, the hashtag is hashtag EPHP 2016. Some of my friends will also help pick up questions. If this is a live feed of the Twitter handle that's coming up. If you want to say anything, tweet your thoughts. Even while the program is happening, we'll see how we can bring some of those into this conversation.
Yeah, it's a fascinating sphere, and I think I'm happy that we are catching up in third edition with social media. So yeah, before we engage them on a specific questions, I would, given that we have given some sort of snapshot, I would like all of you to make brief opening remarks where you could just reflect. Maybe you want to catch up on something that you heard now, or maybe your own experience of being in this fora for a while. So I'll start with Dr. Soumya Swaminathan. Madam,
Yeah, I think that I wish I'd had more time to have been here. I mean, I was supposed to come yesterday morning, and I was hoping to have listened to some of the. So it's very difficult for me to give feedback. I got a flavor of what was discussed. I think it's an important area. It's a growing area, but there's still far too few people, I think, engaged in this. But I think we have to keep ensuring that the dialogue continues, engage as many people as possible from all the different spheres. And I think this is one field where we have to go all the way from community, the participatory research that you talked about, because without that, I think public health is not going to be very successful. Our delivery programs will not be successful. The other area which is, I think, under emphasized is the socio-behavioral research, or more of the qualitative research. I think we rely much more on quantitative research, on surveys, on numbers, and so on. But surveys tell you what's happening or what's not happening that well. For example, malnutrition or anemia. Why do the numbers not really move? Our anemia numbers have remained the same for decades, and malnutrition under 5 is going down very, very slowly. So just doing survey after survey is not going to really get us anywhere. So I think we really need to do much more in-depth questioning, analysis, focus groups, mixed methods research, and use all the different new kinds of methodologies. So I think biomedical researchers, social scientists have to come together.
right.
And of course the community. So perhaps these 3 groups of people working together might actually achieve results on the ground.
Certainly, thank you. I think that's what we also aspire to do as part of EPHP, and we need to really broaden up our audience. So, Dr. Sanjeev Kumar, would you like to make some remarks?
Thank you. I would say an very good feast was laid out for us to reflect on what are we doing? Are we doing the right thing? 2 things come to my mind immediately, reflecting on what has gone on in the morning. I attended all the session and a few sessions yesterday and the inaugural day before. One is we have to change mindset of all of us and everyone working in the field of health. We are trained, and as was correctly mentioned, we are doctor-dominated community. Those who are trained in public health, not in clinical medicine, also are disease-focused. When we look at causes, We look at medical causes of death. To give you an example, maternal mortality ratio, maternal death causes are same here, same in England, same in US. So we stop there. If you want to address equity, you have to go to social causes. Why mortality is higher? Because equity or inequity in health is not determined by what Ministry of Health does. It is determined by many other ministries who are not doing as much as we need to do. Give you another simile from the developed countries. Most of the decline in mortality, child mortality or maternal mortality, took place before most of the invention in medical technology came around. That was because of improvement in water, sanitation, living conditions, and other things. So one is change the mindset that if you want to address equity in health, you have to look beyond health sector. Second is we have a mindset, and another drawing upon what Professor Sundari Ravindran said in the morning, we have a blame mindset. These are the people who bring down the averages. And then you come up with terms which are used by people, think tanks at national level, Bimaru states. You know, you're blaming the people who need services more than rest of them. So please change that mindset. Don't look at those who have worse indicators as someone who is bringing down the averages and they are probably to be blamed. So these are two messages in the beginning. I will say, start looking beyond medical causes, look at social causes, you will address inequity. And second is, don't blame those who have worse indicators than rest of the population by giving them names like Bimaru or whatever. And that reflects the mindset even at highest level policy advocates by reflecting on these people as the ones who are the ones to be blamed. Though they are the victim, they need more help than rest of us. Thank you.
Thanks. Dr. Suresh Mohammed, I know you have been you joined today to us, but yeah, any remarks out of?
I think must congratulate IPH for bringing this theme of equity back to the focus. You know, as having implemented schemes across my career, equity is something which we forget in the midst of all those targets of achievement. Then hardly any equity-based targets. All are some target or the other which doesn't have much equity focus. So you have managed to get that back on the theme, and for the implementer, it's very important to keep that in the background as they go on and implement various schemes. So I think it's a work in progress, but it's important to remind people about it. Thank you.
Thank you. Dr. Sadhana Raja.
So at the outset, I'm honored to be representing our Dynamic Principal Secretary on this forum, and really honored to be amongst the panel members here. So being on the kind of a supporting system to make policies in the state, with whatever the minimal experience or of that, what we are doing in our role of being a state health system resource center, what we look at is the factors that influence policy making. So though there is a lot of evidence that is available through lots and lots of research that happens in different domains and other things, there is some kind of a gap. I feel that the people who actually do policies may not be looking at the linkage between the research or evidence and the whatever the need of the people and exactly how we are implementing. So we don't know how, maybe a mechanism has to be formulated where the PRI, which is a very, very strong kind of a influencers of whatever the programs, the policies of in the country and at the state level as such, maybe there should be some kind of a mechanism to bring all of these people who are responsible to make a policy onto the same forum, where a collective decision happens instead of a fragmented, because what ultimately emerges as a policy wouldn't be exactly the one which got formulated basically. So most of the times, it may not be 100 times that happens, but most of the times this fragmentation happens where the dilution of the entire, the subject of what was intended to gets the dilution at the level of the decision making, especially at the highest of the powerhouses. So maybe through all these forums, which is an excellent, engagement of all this and bringing all the researchers together, should kind of translate into action where slowly, if not immediately, slowly kind of bringing all the factors which influence policy making onto a same platform, so that the actual intention of making that policy remains. This is it. Thank you.
Thank you. So broad-basing policy making process. Thank you very much to all the panelists. I think Prashant and myself will pose some of the questions to the panelists, and then we'll have adequate time, I think, for the audience to engage. Well, I'll start and pick up from what Dr. Soumya Swaminathan said. I remember in the inaugural ceremony of EPHP, Dr. Abdul Ghaffar of the WHO Alliance, he was talking about the paucity of health policy and system research globally. And he in fact cited ICMR, I think 2014, saying that how some 2.4% of the ICMR research resources were accounted for HSPR. So, I mean, not just ICMR, but you steering the health research in the country, would like to hear your remarks on how to prioritize health system and policy research. You talked that, we need to go beyond biomedical research, we need to engage with other scientists. So how you think we can go about it?
Mike? Is mic on? Yeah.
Yeah, thank you for that question. And I was just talking to Dr. Sundar Raman earlier and talking about health systems research in ICMR. We have, a department of one who handles health systems research. So I think obviously the way forward is to have a consortium or a network approach where, like-minded institutions across the country. We have small groups of centers of excellence, pockets of excellent people, 1, 2, 3 were trying to do some work. So I think if we can develop consortia, then we can have a much more powerful approach where we could have a common theme or a common protocol even that is implemented across. That's something we're trying to do in mental health, and maybe we can start doing that for health systems research as well. The other thing that ICMR, I want to give a big push to is implementation science.
Right.
Or implementation research, which is very much linked to this. And again, which is not very well understood. I think people are more comfortable with the term operational research, but implementation science is bigger than that, it's broader than that, and it covers everything from cluster randomized effectiveness trials to cost effectiveness analysis to meta-analysis and so on. So we want to now put out more calls for implementation research. And there you see it has to be a team approach.
Right.
It cannot be a single investigator initiated kind of a thing. So you have to have a team of either an epidemiologist or a community medicine person, a social scientist, statistician, and perhaps a demographer, and very importantly, a program person, somebody from that state or national health program who's involved right from the beginning in asking the question which that research is trying to address. So without that, it's not implementation research. You have to address a challenge of the health program. And so we was recently successful in getting the Global Fund to India, the grant that they give for AIDS, TB, and malaria, to set aside a small fraction of that grant for implementation research. This is there in their manifesto, but nobody actually utilizes so far that fund. And it is called MNE or something like that, and then it's just, most countries never know that it can be used for research. So this is the first time actually that in India, at least for TB, we were able to do that, and we worked with TDR.
Right.
Their researchers came, we had a workshop, we had teams from all over India, about 15 of them were shortlisted. They underwent a 1-week thorough training with mentors in implementation research. They made their protocols better, finalized them, and now they'll be funded for the next 2 years to undertake that. And the program, the Central TB Division has been involved right from the beginning. And they actually gave the priority areas where the program actually needs answers to some of the questions. So all the research has been developed around those priority areas. So I think using that as an example, I think we could do this in other areas, maternal and child health. So we've been talking to RCH division on both on child malnutrition as well as on anemia, and also pockets of high maternal mortality in some of the districts of central India. Tribal health again is something that we really need to focus on. So in all these areas, I think the way to go is implementation research, and that's what we're going to push.
Yeah, Prashant.
Let me pick up on the thread of implementation research. There was also this recent interview, some of our colleagues, we had shared and discussed it in Fountain Ink that you gave, and your message was that we need to make this kind of research which studies implementation processes, understands bottlenecks, and helps to understand this better, which is great, and I think it's really commendable and needed. But one thing that's coming up, we had this workshop that Dr. Sundari Ravindran led on doing health equity research. And one of the themes coming up in the workshop is about how much can we achieve with tweaking and pushing health services. So there is a lot to achieve there, no doubt. But if we are talking of tackling social disadvantage, so the unfair nature of this social disadvantage that is often pushing this inequity that we see. So how do you see the role of researchers, ICMR, also in taking on research on the underlying social disadvantage? And here you bring in things like qualitative research, for which, for example, in the Indian Journal of Medical Research, which is one of the premier journals we have today in India, I frankly find very little scope for inquiry around social determinants of health or qualitative research.
No, that's true. So as I mentioned in my opening remarks, I think that's definitely underappreciated, and we need to bring that discourse in as well. And it can only be done when you have multidisciplinary teams working on these. So if it's again going to be a team of doctors, then you're never going to get that viewpoint in. And in terms of inequity, I think upfront we need to really put that on the table when you're designing your research. Most of the time, the challenge for the health program also is related to inequities in terms of even access to health, and the worst health outcomes are in people we know with poor access, as well as with other determinants of poor health like housing or safe water, sanitation, and so on. So in some of our implementation research, we have said go beyond the health sector and involve. So in the tribal areas of Madhya Pradesh, for example, with very high TB, a lot of it is linked to their housing and indoor air pollution, smoking, malnutrition. So we worked with the district collector to see, can we now tie up with their housing programs? So while you're strengthening the TB services, you're also trying to improve the housing, nutrition, and things like that. So I think it does give scope to go beyond the health sector.
Thank you. I think one other thing in today's morning plenary came out was that a lot of, I'm one of the prominent channel of getting research into policies today remains the expert driven, the experts who are on committees and various boards. And you highlighted how there is need to synthesize available evidence of all ongoing research. So I'm wondering, maybe this applies to both. I would like to ask you, Madam, and also Dr. Sanjeev Kumar, that what kind of plans are there now in the country to synthesize the ongoing research, to package it well? And I guess we have been hearing about, I knew there was this thing about National Observatory on health research by NHSRC. Madam talked a little bit about the Health Technology Assessment Board. Maybe these are probably in the same direction, but if you can give a little more concrete idea about its status today and how you plan to sort of make it operational in coming years. Yeah.
Just to add to that as well, I think Kabir in one of the morning sessions mentioned a national knowledge platform as well as a repository of HPSR and furthering HPSR, perhaps in the same line to also reflect on these bodies.
Now, I'll take you to a broader term, and I was very happy when I looked at the title of your current conference. It talks about evidence. There is a lot of evidence out there, even without carrying out primary research. In my inaugural address, I said, there is a lot of information coming out of HMIS. Are we using it? Most probably not. There's a lot of information coming out of the surveys. There's a lot of countrywide surveys, National Family Health Survey, 4th round has been completed. Are we using it to improve situation of public health in the country? Probably not as much as we should be doing. Then you have many special surveys being carried out regularly on the request of one ministry or the other, or one research organization or the other. So let's move the title from research to evidence. And wherever you have evidence gap, and the focus should be on using the evidence rather than producing evidence. I feel there is a lot of evidence already, we are not using that evidence. So the whole focus needs to shift to making use of that evidence which is already existing. I certainly feel there is a gap in generating more evidence, but what about the evidence which is already there? So that cultural shift needs to come in using the evidence, and wherever we have gaps. And in NHSRC, we used to have a division called Health Management Information System. We felt health management system is very small part of evidence. So we have now changed the name to call it evidence division. And evidence division could not be a standalone division. They have to work with the planning and monitoring division. So it has been merged with public health policy division, which will now be working with evidence and looking at evidence more closely. So that shift needs to come in the ministries, at the district level, even at the community level. Look at evidence. Then how is that evidence getting into, we call it decentralized participatory planning, and NRHM was supposed to do that, but that's not really happening. Engage other sectors. It's very easy to engage them at grassroots level than starting at national level or state level. So one is that shift. Second is many of these fora needs to be created. Lot of research, 47 or 50 research papers were presented. Many of them I saw very high quality. How are we taking them to next level? Prepare guidelines, how the evidence which all of you have presented will be used in planning. In the next program implementation plan, state will use that evidence. That step we need to
So what do you think, sir, that these 57 studies which are now published, what as organizers of this conference can do beyond this 2 days program to make sure that it reaches to, and fits into the ongoing program? Because a lot of studies are actually about the ongoing government programs and policies. So as an NHSRC head.
So we have had discussion, me and Dr. Devdasan discussed that we will look at what is the synthesis of evidence on addressing equity. And then maybe after you get over this period of hectic 3 days organizing this, start putting it on paper. And then we will work with you, and based on what comes out in the paper, what are the messages for the grassroots level planning process, to integrate those messages. And that's what we will maybe next about week or 10 days, we will look at what is coming out of the evidence presented in around 50 studies, and how can we take it to implementation stage. And that's what makes me feel restless. Maybe those of you my age feel restless where not much is happening in health in India. We are shooting up economic growth, IT, we are one of the world leaders, but in health our indicators are worse than many neighboring countries who have much less income. They have no technology. But we need to do something more.
Yeah.
The evidence needs to be taken to grassroots level, needs to be implemented today, not wait for new forum to be created, new research body to come up and take. That certainly needs to go on. But we need to start action today based on what we know today. That's where I get restless. We need to be more proactive in happening things happen today, change things today, rather than in future.
So Dr. Swaminathan, about coming back to that issue of synthesizing evidence and sort of creating a fora where we can actually look at ongoing health research and not just one institute sort of doing particular work.
So in ICMR also, we've created an evidence to policy unit.
Okay.
That's newly created. So there again, the idea was to try to synthesize. ICMR supports so much research across the country, both within its own institutes as well as extramural across, medical colleges and others. And those, as I said in the morning, get published as papers. Sometimes there are reports. We have done huge task force projects, involving thousands of participants, so many investigators, but then it goes as a task force project and doesn't necessarily get translated. That knowledge is not used. So the idea is now the evidence to policy unit would scan Of course, 2 or 3 people can't do everything, but at least start picking out what are the leads from these researches. Particularly, we can take neglected diseases, we can take non-communicable diseases and so on, and then prepare policy briefs that can then be submitted to the health secretary, both at the central and state level. Definitely, we'll be working closely with NHSRC in that. They are also working on treatment guidelines, which is also part of standardizing the quality of this thing. And then the HTAB, once that comes up, the Health Technology Assessment Board is not going to be a few people in Delhi who are going to be working. It's going to essentially be a network of institutions across the country, each of whom will have some strengths. We want to train more people. So we're having the first workshop at the end of this month.
Okay.
And the idea is we've tried to invite as many groups as we could think of who have some expertise in some aspect of health technology assessment or evidence to policy. And then, of course, we will need more capacity building and training in different areas. So in the future, in a few years from now, we should have a robust system where we can really assess technologies, interventions, and based on which the departments of health should be able to make policy decisions a little more.
Yeah, that would be quite.
That's
a
going to
good
take
link.
a few years of building up that capacity, identifying the needs and identifying the right people, training them, and then ensuring that those groups are then working in a very nice sort of a consortium.
Right. Thank you. Dr. Suresh Mohammed, I'd like to engage you now. I think, one is that the researchers do research and then try to sort of package it well to the policymakers. But there was this point that within public health system, there is an enormous amount of data being generated. And probably it is not being used adequately. It's not being analyzed adequately. You mentioned HMIS. So what are the kind of barriers and what is it that we could do to make sure that even within the system, whatever data is being generated out of the programs could be analyzed and could be used to, in turn, tailor those programs well?
See, first of all, policy implementers are the state health departments and various bodies associated with that. They have hardly any time for research. They are caught in the rough and tumble of implementing and meeting their financial and programmatic targets. Research is the last thing on their agenda. I was the mission director of the state. We used to get proposals once in a while from multinational research bodies and national and medical colleges and so many. Generally, there is a sort of hesitation to give clearance for any sort of research which involves the health department because this PATH, there is a PATH organization which did some vaccine trials and a whole lot of people got caught up in that. I think the shadow of that thing is still hanging large. So generally, there is a hesitation to take up any research which involves the patients which comes to the government health system as the subjects. This is a fact of the matter. You take Karnataka, you take any state. So the first tendency of a policy implementer is to just keep it out of the way and just go ahead with the implementation. So we have to change this mindset, as ma'am was saying. Maybe it's important to have some policy research unit in the health departments and in the missions of the states. Otherwise, research is given very low priority. It's seen as a headache and you just get rid of it and go forward with your implementation. The second thing is about HMIs. HMIs is a huge platform available for us. As Dr. Sanjeev was saying, a huge amount of data is available, but data is a perishable commodity. We don't realize that. And we have one joint director in the state, one or two assistants to do all the sort of research and develop the evidence from that data. HMI is a huge amount of data. At the Government of India level, at least it's a little more better organized through the Department of Statistics, sending quite a few people to the Ministry of Health. At least they do it better. It's still there also, having worked as a director there, I can tell the amount of evidence generated from the data is still minuscule compared to the potential. So having seen both the state and government and the central government is still figuring better. State government is way below what is required in terms of generating evidence from this. Then NHSRC is a very premier body as well as State Health Resource Center. But they are also too engaged in many other things. They are the fallback mechanism for anything at the central government. At state government, they do whatever required to support the system. So evidence is simply not being generated. My suggestion is HMIS should be kept open. We have to make it fully open access to everybody.
Right.
That's one way institutes like IPH or PHFI or departments of preventive social medicine and medical colleges, all of them can use this data and get wonderful evidence from that. We are more concerned in the state health department with cleaning that data, getting timely collection of data, making those very routine reports, sending into Government of India, sending into people, and that's all we do. That is our main concern. Then SHSRC does some amount of, but they're also caught up with huge amount of activities going on. I think it is high time we make it open access and give it to experts and let them also, the more criticism we get, the better to improve the health system. So that's my take on the data which we have.
Thank you, sir. Just would you like to respond on that? Yeah, please.
So as far as HMIS, for whatever the inputs we would like to give it is about what I was also trying to present in this forum about MCTS, where one another a tool that is there about the tracking of mother and child. So what we usually find with the government systems is that the users are in lakhs of numbers with a diversified knowledge levels, diversified kind of a perception about these softwares, kind of a reporting system. So unless we get into the shoes of these people on using it judiciously or the purpose actually how we should be able to use, if that is not kept in mind when that software is made and just rolled out across the things, what leads to lot of confusion among the users. And I really appreciate the idea of keeping it open for analysis to all the organizations without any kind of this thing, post data keying in. But what is happening is the data that is getting keyed into these systems itself is sometimes a very, very kind of a thing which may not be useful for any kind of a planning at all if you look at it after the data is keyed in. So basically, I would personally feel is that the data management systems should be user-friendly, where the ANMs or the grassroots level workers, health workers who are going to feed the data should be able to understand the validated data to be put into the system. So if this kind of a thinking happens at the place where these systems are made and given it to the, rolled out into the systems, may lead to a lot of cleaning of data, and the data that we get may be useful for some kind of a planning and something like that. Not that the whole data is wrong, I'm not telling about that. If we can rectify these areas of fault, like I may commit a fault just by keying in some of the irrelevant data elements which are not concerned with me, but as an ANM I don't know that they're irrelevant as far as what I am doing. So this has led to a lot of accumulation of data which is not necessary to be into that particular system. So while having a good data MIS systems, it is very important to have a system which can raise flags about wrong data that is being keyed in, both at the user level and also at the next levels of the directorate which handles this data and other things. Unless these things, and we have vertically so many data collection mechanisms in the form of softwares for so many programs. And the same person, an ANM or a medical officer, will be using so many MIS systems. It is not a single platform. The data that gets into that sometimes gets duplicated, and also sometimes I get a doubt once I have keyed in one of the systems that the same data is asked about in another system, I get a doubt whether that is right or wrong. So with that element of doubt, I key in another. So there will not be a parity, there will not be uniformity of data and other things. So there must be some mechanism where integration of all data management systems happen, where about a mother, the same kind of a data is available everywhere. So these are some of the few things that that may lead to proper data collection, which will be useful for policy making.
Thank you. So we need to strengthen it, but I think it's a really nice idea to play with, to open up the HMIS to broader public domain. Shall we?
Yeah,
Yes, Prashant.
just to
And then
say
we
that
open
I
up.
think some of the Twitter followers have initiated a poll on the thing. Among the audience, I know that Dr. Soumya is on Twitter. In fact, we've been bombarding her with questions by tagging her. I don't know if she's had the time, but it would be nice to also hear from you in case something, in case there is something that you pick up on Twitter. Before I think we have to soon open up to the audience. I'm sure there are many of you who have things to ask. One last question. I don't know, Upen, if you have anything else to
No, fine,
say.
go ahead.
Is about the evaluation. We are talking of data. In general, I think the culture of evaluation of policies or programs seems to be rather low. Of course, in the morning, Dr. Sundaraman was mentioning about the inbuilt evaluation in NHM. Perhaps landmark, I mean, sort of big programs at the Government of India level are. But I'm interested in hearing your thoughts. How do we get the evaluation agenda going? Because as researchers, in many sessions this came up, how the evaluation community, be it in countries like Australia or in UK, where there's a very embedded, evaluation is embedded into all policy making and program making. So how do we get that agenda going, both at the government level, I mean, central government level, and especially at the state, where a lot of action is with respect to health policies and programs? Ma'am?
I think two things I'd like to follow up also on what Dr. Suresh was saying, and also related to what you just asked. I think it's exactly right that we don't build in impact evaluations into our programs. Some of our programs do have, like NHM, the IDSP has an external evaluation, the TB control program has an external evaluation, the AIDS control program has an external evaluation done every few years. So that is there, but I think we ourselves can do it. I mean, we don't necessarily have to have a huge bunch of people coming from outside to evaluate, but then we must do it very openly, transparently, and with the view to learning lessons. So an impact evaluation budget, I think, must be kept for each program that we roll out, especially the new programs or even existing programs where we feel that things are not really moving in this at the pace at which it should have been moving. And that, I think, will pay a lot of dividends. If we set aside some funds, I mean, we can call it research funds, or so the National Health Policy, for example, talks about 5% of the health budget being set aside for research. And if that can flow through each of the programs to a fund that's set now, sometimes what happens is that money is all returned unspent, because the program actually may have some amount set aside for research, but if there's no plan as to how to use it, then it's going to be returned. So I think that component could be handled by research organizations. It could even be coordinated by CMR, again, through the network of research organizations in the country. And depending on the particular expertise, people could pick up different programs to do the impact evaluation. So I think two things. One is that secretaries of health and mission directors could set aside funds within their own. And I must mention here that the government of Telangana, the first state government that I know of that set aside money for health research, not impact evaluation of programs, but just health research. And the DME told me there's 12 crores. And she approached me and she said, now how do we make sure that our medical college can actually utilize this fund? So I think that's a very progressive step, that a state government sets aside money for research, and certainly there'll be enough people to partner with the medical colleges to ensure that there's good quality research going on.
Interesting. So maybe we can open up, but as Ma'am mentioned, I was just curious. Ma'am, we have been hearing for many years about a national health research policy, and there have been few drafts. So maybe if you can just give us a status update on where it is. Are we going to have some? Because I guess what all we are talking can be well articulated in one sort of a policy statement at a national level that can remain a guiding
True, I
document
think-
for health research.
Yeah, you're right. It was there, I think 2007-8, the draft was developed, put up, and then after 2011, it vanished. Now we have to, I think, either revive it and then maybe look at it again and this thing. But meanwhile, we are working on a strategy for
Sure.
for research for, at least for ICMR, and there are going to be 5 pillars in that strategy. Implementation science is one. Data systems and data repositories is another one. And as we were just talking earlier, we have huge volumes of data. And if you have to actually access it, it's a pain, you know. You have to run from one agency to another. So we're trying to see whether we can have a platform where we can bring that AHS, DLHS, NFHS, you know, the maybe HMIS as well, and all the big surveys that are conducted. National surveys can be all put on one data platform and make it open access, anonymized data, let people use it for secondary data analysis. So that's the second pillar. Our third pillar is building capacity for research. How are we going to do that in the future? And we really need to expand that. The fourth is evidence to policy. And the fifth is leveraging traditional knowledge. So these are the 5 pillars on which we're building our strategy for the next 10 years. But the health research policy as a whole is something that I have not really taken up. Maybe we can.
Maybe the agenda,
There's
agenda
it.
for the future. Yeah, I think making data more accessible seems to be quite a thrust now. Maybe we open up, Prashant.
Yep.
Yeah, you help me moderate, and I'll just go down, help
Sure.
passing the mic.
So I think the format will be that we're already at 3:10, so we have time till 3:30. We have about 20 minutes. We'd really like to hear your thoughts, comments, or questions. Please be very brief when you ask. Please do not. I know there's lots to say, but please try to be brief, and please begin with an introduction to who you are. One-line introduction. The only mic will be through Upen, so that there's not too much confusion. So you just get the attention of Upendra Bhojani, and he will come to you with the mic.
Hi, I'm Neeti Rao from Institute of Public Health. I echo Dr. Sanjeev Kumar when he says health is not just the business of the health department. My question to the panel is, how can researchers put health on the agenda of non-health ministries, departments? What can we do?
Let's take a few, and then we can get some reflections.
I'm Dr. Chaitanya. I work in public health communication area. My question is, India spends very less on, as a percentage of GDP on health. Is there a chance of improving that? And if they do, will it really help? And the other second question I'm interested in is, we have a national essential list of medicines. And since health is a state subject, there's a lot of equity in the availability of medicines in individual states. So is there something that can be done to improve that?
Okay, and I take a liberty before I pass the mic to the next person. I think Neeti asked about how we can put health on the agenda of other researchers. And I was at Delhi before a week or so, where there was a national consultation on NCDs. And in panel discussion, there was a remark by a ministry person saying that there is a thinking about institutionalizing something like a health impact assessment in line with environment impact assessment. So maybe you can, some of you, maybe Dr. Soumya can comment on where the thinking is going in line.
Yeah, I'm Chandar from Swachhara. Dr. Sanjay mentioned already how to, the challenge is to, you can throw them light how to use the existing evidence, the huge volume, how to. And then I understand, so it's not the lack of evidence, bringing evidence into, now so how is the focus. And in the morning also panel discussion I picked up, definitely the various vested interest groups influencing the policy makers. So how I stand behalf of the people can support you, strengthen you, people are involved in the system, and we have less access to, as a vested interest groups have more access and power to the policy makers, right? So how can we influence you people in the system towards this evidence for policy making? And also definitely we have to have access to, through some form, to the political system also, but how we can strengthen you and how we can use the existing evidence itself, how we can, a civil society or a public health professionals can.
Yeah. Shall we have one more, and then we can have responses from the panel? Your mic doesn't seem to be on. Yeah, go ahead. Your mic is not on.
Why don't you use this?
Sorry. Myself Kandar Talati, and I am working in a tribal health in Gujarat. Madam, as you told about the data repository and including the bigger data sources, my suggestion is when we have a research funded by agencies like ICMR and others, and when there are a particular call for proposals, it is likelihood that there may be 5, 10 or 15 researchers across the nations working on the same issue of maybe MCH or something like that. Is it possible to have the open data repository at the end of the ICMR or the funding agency, whereby the experts could look into and can guide the further? Because suppose if the same study is being done by different researchers across the country in different parts of the country, we could try to have some similar data gathered by them, and that could be analyzed to guide the policy actions. If required, the research could be taken further from that also.
Yeah. Shall we have one round of responses from the panel?
Yes, that's $1 million question. How do we get other ministries to put health in their agenda? I will take you a step back. How many people within Ministry of Health or outside working on health themselves realize what is the importance of other ministries working for health? So we have to change our own mindset that lot more health can come from outside health than within health. Coming to the global initiative, you have two initiatives. One was social determinants of health. The commission gave reports around 10 years back, and there was a commission in India which looked at social determinants of health. Another initiative at global level which is being rolled out across the world is health in all policies. So these are the initiatives. Within Government of India, there are many programs under which intersectoral action has been put in place. National Tobacco Framework is one. Non-communicable diseases, HIV/AIDS, most of us are familiar, started looking at other sectors, and they created National AIDS Control Organization, which was outside Ministry of Health, because it was a problem to be dealt by other ministries more than Ministry of Health. Ministry of Health was only for detecting cases and treating them, but lot more action was outside. So Ministry of Health has put together all these initiatives into one folder, and they are reviewing how we can integrate health in other ministries. So there is a thinking going on. It still needs to crystallize on, do we have health cell in all ministries, so that this cell looks at all the projects and all the programs and plans to look at health implications. Do we have health impact assessment, on which we have some experience across the world? So that thinking is going on, but hopefully very soon we will have a structure which will be agreed by Ministry of Health and approved by the cabinet, because this needs to go beyond Ministry of Health. So some work has started into that. Evidence into program and policies is very important. And I often ask all those people who are working on HMIS global level within the country in an organization like mine, who is the most important person for HMIS? And I rarely get the right answer. The most important person in HMIS is the first person who puts the data on paper or in digital world, puts it on computer or whatever mobile phone or whatever he is using, because he or she is the person who knows exactly which child did not get vaccinated. At district level, state level, national level, INU look at 80% coverage. But the person who put the data first time on the paper exactly knows which child is missing, which antenatal mother did not come for second checkup, third checkup, and so on. So we need to start using this right from bottom upward. Similarly, Mother-Child Tracking Center, Dr. Sadhna talked about, the first person who puts the mother who became pregnant on Mother-Child Tracking Center, she has all the information on what needs to be done. So we need to change that orientation as well, that most important person is not the program manager sitting in Ministry of Health in Delhi. Most important person is the person who puts the data on paper, because she is the one who can address the issue of the child who didn't get vaccinated.
Any other thoughts? There was also some questions around inequitable access to medicines and vested interest groups, or perhaps on anything else.
For the policy, how to change the policy in the other ministries, I just wanted to add to what Dr. Sanjeev has already said, that we also have to generate data. Because if we just tell them, do this, do that, and then they'll say based on what. For example, this indoor air pollution, that women are exposed to because of solid fuel use, really there hasn't been a lot of work done. to document what are the impacts on health. It's not just on respiratory health, but it's on cardiovascular, it's on the health of the unborn child as well as after the child is born. Child sits next to the mother when she's cooking. And so if we had documented that earlier, we could have put a lot more pressure on the policymakers to try and change, make an alternative arrangement for the indoor. So I think whether it's outdoor air pollution or indoor air pollution, or whether it's the question of green spaces in cities for physical exercise and so on, I think actually doing the studies and generating the evidence would also help to when you go to that particular ministry and say, you need to change your policy. And the data repositories, I think I very much agree with your suggestion with thinking along the same lines that ICMR funded studies or any government funded studies for that matter, the data should really come back into a repository that can then be made available to the public. And many agencies across the world, research funding bodies have started doing things like that. So we're also thinking, of course, we have to set up the systems because to handle that large amount of data volume. But I think that's the direction where we should be moving.
Great news about open data. Any thoughts, sir, about, or perhaps anybody else also on this interesting question on access that relatively more powerful groups than researchers have to influence policy? And I think perhaps he's alluding to food or pharma or big businesses or private sector, because they also not only influence policy, but they also influence the research agenda on what needs to be. Any thoughts, reflections, how to make more access available to researchers and less powerful groups, or as community groups and things like that?
Well, I think one of the things is to have transparency in decision making, to have a strong regulatory body who's above influence. If you have the regulator who's answerable to, who's at a lower level of government, then it makes it very difficult for him to really be. So taking the example of NICE, for example, the NICE, came up with quite a lot of controversial decisions, and they were not very liked by pharma at all. And there was a whole systematic effort made to destabilize NICE or even have it closed down. And head of NICE at that time was being maligned heavily. That was because the decision had been made to not go for an expensive medication. But because of his position and the visibility he had, and also the relationship with the head of government said, no, I have full faith in NICE and I'll take the recommendations that they give me. So that then, once and for all settles the issue, and then vested interests also get the message that the decision making at that level is going to be done on a set of principles, which cannot be compromised. So I think those kind of clear messages have to go, but then this is a fact of life. I think that we have to live with it. And as long as we put everything on the table, we are open about discussing, and having them at the table also is, I think in a way, it's a good thing that you have the commercial interests also on the table. But I think the regulatory system being very strong and above any kind of influence is very, very important, and we have to try and get there.
Thank you. Any one more round of questions, perhaps?
I'm Dr. Gunjan Taneja, working with IPE Global. I think now the time has come that we first break down our internal vertical silos. So we have a triad of policymakers at one end, implementers at another end, and sort of researchers bridging the gap between the two. And it often translates, we being in the, supporting the implementation, or implementers often tend to forget how to address the last mile. And that is where the research now needs to be focused, and possibly we now need to move from the question of addressing why to the question of addressing how. And possibly researchers now working hand in hand with implementers to guide them on how to take things for the different programs forward. For example, just taking a minute of your time, Government of India came out with the national guidelines on advanced distribution of misoprostol for prevention of PPH. The guidelines were launched in late 2013 and it's 2016, and just the state of Himachal Pradesh has been able to do some work on it, and that also in a proper manner in one block. So the time lag needs to be sort of bridged down, and that can only be done when the three wings come together and work holistically together to address existing challenges. So it's just a submission.
Sunil Nandraj, various places. This repository thing, when Sujata Rao ma'am was a secretary, one of the things was so many studies were being done, same studies. And I drafted a letter, I said, ma'am, sign it and sent it off to all the agencies. Because the problem of trying to find studies was you go to the agency which has conducted the study, oh, we cannot share it. It is with the funding agency. We have to get their permission. You go to the funding agencies, they give you some stories. So I got a letter shot off from ma'am and sent it to all the funding agencies. And we tried to institutionalize it that from now on, any studies you fund, it has to come to the Ministry of Health, Government of India. That time it was. But sadly, we didn't have that kind of capacity to keep it and put it down and all that. And I've been advocating at the state level, at least, where you could do that. And it is possible. See, the funding agency is always worried of Government of India. One letter from them, they start getting worried and they will start sharing anything. So we can push the agencies to start sharing because they are the major funders of studies. Having said that, I think there is a whole lot of things that one can do. At least when I was in WHO, I got all the committee reports, right from the Bore Committee to the National Commission on Macroeconomics, digitized and put it on the website. And that becomes a kind of a treasure now for people to use it. So it's not that data is not there. The second important thing is, we keep asking for data, but have you looked at the secondary data that is available already? I have done studies, recently brought out a report from Kerala and Malappuram and Palghat on the universal health coverage on assessment. I was able to identify 150 sources with 500 variables of data. There is data lying at the district level, at the state level, but please, many of us don't look at it. It is there, and it's not that it's hidden, it is under CBI or something like that. No, it's there. How do you access it? But many of us don't even look at it. And I go back to Dr. Sanjeev sir, what he said. So many studies, NSSO 71st round, 4 rounds have come, NFHS. How many papers have come out of DLHS or NFHS? Frankly, how many studies have come out? And we ask for more data. I think we need to really look at, and last but not the least point, we are talking about data, but here I didn't hear one word about private sector data. If you look at the utilization, 30%, we are only tinkering with the 30% of the public health system, that data. Whatever data you talk about, morbidity, incidence, whatever, it's this government 30%. But there lies a huge data of 70%. We don't even know how many hospitals are there. We forget their numbers. I mean, we don't know their outcome data, all kinds of. Let me stop you. Thank you.
Any other final, we are almost just a few minutes away from 3:30. Any final comments or thoughts, or I can, yeah.
Rupa Devdasan, public health activist and school teacher. I'm hearing again and again that silos need to be broken down. And I'm asking practically, how are you guys going to break down the silos? Because for me, if it ends at a conference, it just won't end. Whereas if you have a group of researchers and you make it a point to call an implementation person and a community representative, you straight away got a balance in the discussion. If you're a group of implementation people, like Dr. Mohammed said, you all are inundated with work and you've got all these things to meet, then just make sure that you have a community representative and somebody from the other side. You just have these 3 or 4 things. And I don't know, see, for me, whenever I see the government working or I see people working, I notice that they go by a set group of emails that has to go out or mails that has to go out. Right? So whose responsibility is it to expand this? I mean, who takes the step back and says, look, I'm thinking afresh. I really want to answer this problem. And I'm going to go all out, even if it means inviting 2 more people to the meeting. I'm seriously asking this question. All 4 of you out there.
Okay, with that, I think that's quite an interesting note to end the question answer session. I'll invite any responses, final closing remarks. You can respond to specific ones as well as have any final closing remarks.
I think this is an important one. There's no magic answer to this, and we have to start at each level we can. So, for example, like you said, at the state level, it's policy maker, say the MD, NHM, or the health secretary is enlightened enough to say that, I'd like to have this policy unit or some research being conducted around health systems and set up a small group of people to advise him. I think at the national level, we're all constantly talking to it. I'm at least trying to engage with the program, people who are actually running the program to say, hey, come and tell us what your challenges are. What are the gaps in knowledge that you need to fill? Then we can help you by putting out the calls for research. And I think community activists need to also talk about it. I think the media is important. We don't involve our community enough, I think, in this whole discourse. The only health articles that come are headlines, so many children died of malnutrition, mothers died of this, or cataract operations which went bad. We're not really having any debate on basic issues of healthcare delivery and structure and how they should be. So I think involving media, and also for us to write more in the lay press. Most of us end up just talking to each other. How many of us are trying to reach out beyond our own constituencies?
Very, very important questions you have raised. And I was just thinking about the questions when all of you were making. If we were able to give right answer to all the questions, I think everybody in this room will get a Nobel Prize, because these are the issues rest of the world is struggling with. And one discussion, one panel discussion, one series of question answer sessions will probably lead us a few steps further, but not really find the final solution. And Prashant prompted, but we didn't take that bait, is we need to coordinate all the research done. And there is an initiative, DHR is involved, NHSRC is involved, Public Health Foundation is involved in creating a national knowledge platform where all the relevant questions from the field come to this platform. They review that, carry out secondary data analysis or review of literature, see what are the questions which can be answered with available information, and what are the questions for which we need to go into fresh studies. So that is in the offing. So hopefully in the next few months' time, we will get that information. And what Sunil said, I fully agree. I remember in a meeting in the ministry, I made this comment that we can do infant and child mortality by district. They said, no, how can you do it? I said, no, census has the whole universe. We have all the births, we have all the deaths, we can do that. And we collaborated with National Institute of Medical Statistics, ICMR, and carried out that, and now the file has been sent to the ministry where we have done analysis by district. You can go down to a block level even, because this is the whole universe. You don't have to look at level of confidence, precision, sample size. So there's a lot more data, as Sunil said, which is available, but we don't analyze that. In many other countries I have worked, they look at census data, go down to 100,000 population level to look at infant and child mortality rate. We need to be more proactive and look at what are the secondary data sources which we need to, and I fully agree with you. We need to break the silos within health, because researchers don't talk to implementers, they don't talk to policymakers. So we have created, there was a program, huge program, National Health Mission, started as NRHM, created to strengthen the system. We created another silo. There are directorate people and there are health mission people. So within the institute, 2 more silos have come up from a program which was supposed to strengthen the system. So then you have even more difficult task of breaking silos across ministries. But that question, we need to keep addressing and keep looking for opportunities to address. If we had the answer today, I think all of us will get the Nobel Prize. But let's make effort in that direction. Thank you.
Silos is, I think, within the Ministry of Health itself, we've not been able to address the silos. Ayush is one. Now apparently it's a different ministry itself. But Ayush and NRHM, we had the very catchy slogan of mainstreaming of Ayush, which never went beyond getting a few Ayush doctors to practice in those BHCs. So That itself, those silos have not disappeared. So then HIV/TB integration took so much time. Finally, it came on board. So within the ministry itself, then there's a entity of nutrition. We had a Karnataka nutrition mission, which initially was with health department. Then it women and child. Now I think it's gone to Panchayati Raj department. Nutrition, nobody knows where it stands. So these are the sort of silos and problems which we work with. So I don't know how we will break those barriers between various ministries and work towards attending those social determinants of health. The second thing is policy is very much in India, health policy at least is very much the policy elites have a very important say. And very few state governments have gone beyond that and done their own work, regardless of what government of India says. But otherwise, policy is very much in the hands of policy elites and very much dictated by government of India. Now, very few examples like Tamil Nadu government have not much bothered about the national policies. They go ahead with their own. The Delhi Mohalla clinics, they have not gone with the routine urban health package given by government of India. They've gone their own way and charting their own path. So there are state governments which are exception, but generally the policy mandate of government of India is what works. So it's not easy to make a course correction over there.
Then again, coming back to Rupa's question about what is the mechanism and how the things can go to the implementers as such to be accountable, to be in a kind of this thing. And this is a huge, again, all our panel members have spoken about, but I would believe in that public participation or a community participation in the form of raising their voices about wrong policies that is being made, or the policies or any strategy that is being made by the government which is not relevant to that particular kind of a thing. Though it is existing, maybe the voices are stopping somewhere in between, as Chandar rightly said, it is not reaching to the place where actually it has to reach. So as Soumya ma'am also said, while engaging media and other kinds of a thing, people to as a vehicles to reach that place, maybe the community organizations, the civil societies, and have to address the persuasion of that. What we have been seeing it is there is a sprout of something and it stops. There is no continuity about that particular issue that goes to that point. And with the government, you have to be persuasive. You have to be kind of, you should keep on pushing some time in. Once, if we just raise it and stop it, it may stop somewhere. So personally, I feel that the community engagement into everything from village level, if not at the kind of, even at the planning of health, should start at the village level, then the decentralization and where the community asks for what they want. Because we keep on telling about the medicines are not there, there is nothing like that. But we don't see that strong community reaction to the government saying that, see, this is it. For example, the other day there was a policy by the central government on PPF, something like that, how the women workforce reacted so that the government had to take back. I'm not telling it is right. I'm just giving you an example of one of the incidents that recently happened to sensitize the government that, okay, this is not acceptable by a kind of a people. So maybe if the community starts getting engaged themselves at every level to see to it that they get what they want from the government, and the accountability where the questioning by the people starts at every level, maybe that slowly brings in that kind of a situation where the government also thinks twice before doing anything which is not needed for the people.
Thank you. Thank you. We are already at the end of the time, and I really thank our panelists for a very insightful and a candid sharing of their perspective on many of the questions raised. And I thank all of the audience for participating very much in this. With this, we come to the end of the session, and thank you very much. After a 10-minute break, yeah, please applaud. Let me not stop the applaud. After a 10-minute break, we will all gather for the closing ceremony of EPHP.
And there is a small announcement. One of our keynote presenter has lost a keychain, elephant-shaped keychain, which has a pen drive and a house key. So if you happen to find it, please deposit on the left-hand side desk, and we'll make sure that it reaches to the right person. Thanks. So there is a coffee served just outside in the lobby.
Thank you very much. Thank you very much, sir. Thank you very much, ma'am. Thanks. Sure.